A big hello and welcome to everyone listening today. We have the delight of another exclusive webinar discussing various endometriosis colorectal-based questions that women with endometriosis are looking to find answers to. Quoting directly from the Endometriosis Centre section of the Bedfordshire Hospital's NHS Trust website, endometriosis is a chronic debilitating disease that affects 1 in 10 women. We now know that's actually due to 1 in 9, so that is really very common. It can have serious physical implications for those suffering from it. It can cause painful periods, pelvic pain, dyspareunia, which is painful intercourse, bowel pain, and we've got some incredibly special guests with us today, and urinary problems. In addition, endometriosis can also make it difficult to conceive. This complex disease can affect every aspect of life, including physical, mental, social, fertility, and psychosexual health. Given the complex nature of the disease, endometriosis requires a team approach with experts working together in a seamless fashion to deliver good multidisciplinary care. Luton Dunstable Hospital is fully accredited, a British Society of Gynecology Endoscopy at BSGE Endometriosis Centre, offering management of all stages of endometriosis. Where to find help? At the Endometriosis Clinic, there is support and integrated care provided by a multidisciplinary team. Team of gynecologists, a nurse specialist, laparoscopic bowel surgeons, urologists, radiologists, and the pain team. The patient will be involved in all decisions about care treatment plans, will always be based on what is right for the patient and their needs. Mr. Eunice and Mildred Lanta, who are part of this strong team, have a wealth of knowledge behind them. They are both highly qualified, experienced, and well respected in the gynecological and colorectal field, specialising in endometriosis. They have been kind enough to agree to be in the hot seat today, and we are hoping for as many answers as possible to questions women have asked in a call to action response placed recently in an online group. Without further ado, let's start the ball rolling. Mr. Eunice or Fras, over to you, please.
Well, thank you very much for hosting me for this very close to my heart subject, webinar on endometriosis. I have been a colorectal surgeon for the past 11 years at the Luton and Dunstable Hospital and now part of Bedfordshire Hospitals. And we started the journey of endometriosis, work on endometriosis in 2013, 2014. We were one of the few centres the first centres that started. And at that time, I think there were only about 12 centres at that time. And somehow I volunteered myself to be the colorectal specialist in that field, thinking that it's going to be a straightforward, not knowing that actually I was dealing with one of the most complex diseases I've ever experienced in my career. Wow. So far it's been a very good journey, and I am very proud that I continue to do endometriosis. And I have served to help so many young ladies with this severe condition that affects them in every aspect of their life. I am a colorectal surgeon. I trained in East Anglia and did the Cambridge rotation. And then I did a further fellowship in advanced laparoscopic surgery in Auckland, New Zealand. And I work at Luton, and I do laparoscopic cancer surgery, benign disease, and 1/3 of me is I specialize in endometriosis, and that is complex endometriosis.
Perfect. Wow, you're very special. Thank you so much for being here today.
My pleasure. How would you like me to start my presentation? Or yes?
Yeah, that'd be great. Thank you.
Let's just go straight into your presentation. Thank you. Yeah.
I will try and share the content.
Very excited. There's a lot of women that have been waiting for this sort of a presentation, and it's so exciting to have this today. And know that so many answers are going to be answered.
Sure. I have a short presentation just to tell you what is actually involved. I am one individual, part of a whole center that has different specialists. And we've been lucky to have people who are dedicated to the center and to delivery of the service. This is a team sport. Without the team, we cannot perform this surgery. This is quite highly complex and quite challenging surgery, because we're dealing with a benign disease in young patients, and we need to preserve their fertility in most cases, and at the same time deal with this complex disease. This is sometimes, I consider endometriosis is even surgically more challenging than actually doing cancer surgery.
Wow.
So by definition, it's any lesion deeper than 5 millimeter. And about 80% of patients with endometriosis that I come across, probably even 90%, will have significant endometriosis. I only get involved basically in very severe cases of endometriosis, because straightforward cases of endometriosis, the gynecologist can deal with. The way we deal with endometriosis is that we have cold cases get referred to the MDT, which is a dedicated MDT for the endometriosis, and we discuss each case, the requirements of each case, the background of each case, and also what we want to achieve. And we always ask ourselves, what can we do to make this problem better? What can we do to make this condition in this young lady sort of better? And what do we achieve? What are we looking for? We're looking for pain and infertility, or we're looking at infertility, because some ladies present with endometriosis as a result of infertility and have very little symptoms. Other ladies have a lot of pain, but they don't have infertility. And there are the others who basically have the combination of the two. And commonly, when it comes to the colorectal surgeon, is often the disease has involved part of the bowel, but not only part of the bowel. It could have involved the ureters or the bladder, and I get involved with all of that work, and as well as the lateral pelvic side wall. 12 patients of all endometriosis cases will involve the intestine, which is a significant. And the rectum and the rectosigmoid, which is the bit of the, so the rectum is the end of the colon, which is also called the large bowel. And it's basically, it sits above the anal canal and just behind the uterus and the vagina. And commonly it's affected there, and it's usually the mid-rectum. So if you think about the anal verge and go around about 10 centimeters up inside the bowel, that's what I actually find the endometriosis. And it's very subtle. A lot of cases get missed because what the physicians who are the endoscopists who deal with general bowel conditions, they look at the mucosa. The mucosa is the inner lining. They don't see and only very small percentage of endometriosis actually affects the mucosa. Only 10% of bowel endometriosis affects the mucosa. 90% of it doesn't affect the mucosa. So when I go in and have a look, I look and see as any subtle signs of narrowing, of basically a compression. So it could be one compression, could be loss of flexibility, rigidity, fixation, and that's what I look for. And now, as I said, there are some cases who are asymptomatic, and there are other cases which are symptomatic, and the symptoms varies, as you've mentioned already. So as I explained, the vast majority of lesions involve the serosa, which is the outside and not the inner side. So we have the serosa, we have the muscle, we have the submucosa and the mucosa, and they go from outside in. and 95% it affects the serosa and the muscular layer. Less than 40% affect the submucosa, and less than 10% affect the mucosa. And that's why a lot of ladies get dismissed when they get an endoscopy, when they present with symptoms synonymous with irritable bowel, and they get endoscoped and they find nothing. While I spoke to the same ladies who were already done by specialist gastroenterologists, and I find that they had endometriosis, and they have severe endometriosis causing narrowing or causing deviation or causing compression of the rectum. And they're very subtle signs. And often the lesions are somewhere between 5 to 10 centimeters. And they are very challenging because it's the lower part of your intestine. It is the rectum. And the rectum has a lot of nerves. And the main function of the rectum is a reservoir. And the reservoir, once it gets full, it gives you this basically the indication that you need to go to the toilet. If there is anything that affects that reservoir, whether it's nerve innervation or muscular function, then there you got dysfunction. And the dysfunction causes inability to evacuate or frequency evacuation, unsatisfactory evacuation, bleeding, and pelvic pain. Now, what we've come across is the iceberg phenomena. The iceberg phenomena, we think that 80% of endometriotic nodules that affect the bowel does not only affect the serosa, the outside layer, it actually goes deep into the muscle. And that is the problem. It is that when surgeons go to shave those lesions, they actually are inadequately removed. And hence, that's what is very important, that we have this multidisciplinary meeting, the MDT, where we look at the MRI, the ultrasound, the clinical scenario, and also look at the endoscopic picture. And we marry all of those findings. And usually these cases presented by our gynecologist first, and Mildred adds to it from a psychosocial point of view and support point of view, because she knows a lot about those patients. Then the radiologist who specializes in MRI, one of the best in the country, Dr. Rachna Shukla, who gives us basically a navigation of the pelvis and the location of the endometriosis. I then add my information of when I scope the patient, I examine the patient, and then we form a picture, a 3D, okay, a frame of what the endometriosis is doing in the pelvis and what we need to do in order to address this problem and plan an operation on that basis. 80% of the component basically of endometriosis in the bowel is fibrotic component, causes scars. 40% is multifocal, and that can be not only in one area, but can be several areas within a short distance and the same segment of the bowel. It can infiltrate the bowel wall, the muscle, the nerves. It can exist in the lymph nodes. And sometimes, if you inadequately remove it, it will reoccur. Any lesions bigger than 3 centimeters that has gone into the bowel wall will warrant some sort of resection. Now, you cannot shave an endometriotic nodule that has called a stricture, a stricture where you've got a fixed narrowing. That causes obstruction. You cannot partially resect it. You cannot shave it. You will have to formally do a segmental resection and join the bowel together. The surgical approach in broad term is either conservative, and that is to basically preserve the uterus, the tubes, and the ovaries. And that is to preserve fertility, and often involves, if the bowels is not affected to a significant degree, it does affect local, basically, we tend to do a local excision at all possible. The risk of recurrence in these patients is about 20% in their lifetime, fertility time. And the other possibility of surgical approach will be clearance of the disease, and that's radical. That will give you the best outcome, but it can include hysterectomy, bilateral salpingo-ovrectomy, also as an anterior section. I must say, in the conservative approach that we have been following, I have been involved with few resections. As I have alluded earlier, it's very complex and very challenging surgery. It can have potential life-threatening complications, but they are very rare and extremely rare. It should be done in a center of excellence and within a multidisciplinary team context, and all the results should be recorded and should be assessed and should be audited. We do have a very careful preoperative planning for every case. We are a specialist endometriosis team. And as I said, we work within a multidisciplinary team. Our aim is to preserve function, that is rectal function, bladder function, ureteric function, as well as fertility. Our aim, and as we've been successful in doing that, probably 6% of our cases have been laparoscopic. We also preserve nerve function because that's important in a lot of functions in the pelvis. And as you're aware, they are very close structures and organs together, and they do have a shared nerve innervation. Also, we would like to improve the pain score and the quality of life. 98% of our patients don't get a stoma. So that is something that they need to know. Stoma is extremely rare, and only done if it is very, very severe disease. And all our patients undergo enhanced recovery program with an enhanced recovery team looking after them from the word go. They see them before surgery, after surgery, and they're following up after surgery. We also have specialist stoma nurses in case they are needed, as well as Mildred and the entire team support. We are very approachable. I'm lucky to work with very nice team that actually believe in teamwork. Now, one other thing that a lot of ladies get in the communications with them from us and from the gynecologist, it is the Enzian classification. The Enzian classification is our roadmap. And our radiologists give us is the severity of the disease based on the Enzian classification. All right? And it's divided into, if it's A for rectovaginal space disease, B for lateral pelvic sidewall disease, or what we call uterosacral ligaments, and left and right. C is for colon, for rectum. And then we have also the additions of adenomyosis as FA, bladder FB, intestine FI, and ureteric FU. And you probably would, I don't know if you've ever seen, we talk about A1, A2, or A3, BB1, BB2, BB3, and that depends on the size of the actual lesions, the nodules that we identify, and we can see clearly on the MRI. The radiologist also gives me the depth of infiltration. So she can tell me exactly how deep that nodule is before I actually consider surgery. If she tells me it's full thickness, then I'll have to know and plan and what to do on full thickness. All right, I hope that helps you so far with this short presentation. I'm gonna start sharing and then we can talk further more.
That was brilliant, thank you. Really, really informative, and I think the ladies will enjoy watching that, so thanks very much. Okay, so we'll crack on with the questions. We'll see how many we can get through. So the first question we have might be one that Mildred can answer instead, actually, which is, what steps are the centre at the L&D taking to reach BSGE status?
First of all, I want to say thank you to Deb and Kat for inviting myself and Mr. Yunus tonight. But just to let you be aware that Luton Dunstable Hospital is a fully accredited center, and this is based on the body of work that we have done from 2022. So we have reached the criteria set up by the BSGE to be a fully accredited endometriosis center.
Excellent.
Yes.
It's pleasing to hear. Okay, so the second question is, if someone is suffering with IBS symptoms due to endometriosis and surgery isn't always required, would you recommend a specific diet or foods to avoid?
Okay. Irritable bowel syndrome is a diagnosis of exclusion. Now, it's interesting that about 1/4 of patients with endometriosis will have irritable bowel syndrome-like symptoms, and that would be bloating, shooting pain, urgency at defecation, or feeling very uncomfortable. Now, any diet, okay, it's the holistic approach to endometriosis is management of pain, lifestyle, and also bowel symptoms. Now, one thing that we would like to know, what I would want to know is that, is there any evidence that the patient has bowel involvement? And if they have bowel involvement, is the extent of it? And two things we could do. We could do fecal immunohistochemical testing to make sure there is no blood in the stool. And also we do fecal calprotectin, and that is basically to rule out any possible inflammation of the bowel. The other possibility, and they're both a very simple examination of the stool that the GP can order in their practice, and they're widely available. The third thing I think is we need to rule out celiac disease. Let's say we've excluded irritable, sort of any other conditions that leads to it, and the endometriosis is not severe enough that requires treatment. Now, it's a trial. It's a trial. So any diet you want to go on is a trial, and IBS may be different to different people. Some patients may complain of excessive bloating, and excessive bloating can be caused by certain food elements. One of them is gluten. So you could do a trial by eliminating the gluten in your diet for 2 weeks and see. But I don't want you to eliminate it unless they say come off of it. And then you basically assess whether your symptoms are a lot better or not. The other thing people talk about are we suffering with constipation? And as a result of that, we actually then have symptoms of IBS associated with constipation, because IBS can be either constipation or loose stools. If we suffer with constipation, then I think we should think about having things like flax seeds, linseeds, increase soluble fiber without increasing the sugar content, and also increase our fluids and increase our exercise, and hopefully that will help with the actual bowel function. We do talk about, there is another diet we talk about, which is the low FODMAP diet, and that is very restrictive. And the last thing I say, everybody has to go on low FODMAP diet, because that is very restrictive. And if we say try this, and patients with endometriosis can try it, then they are restricting their diet to a significant degree. I would say you could try it for about 2 weeks, and then start introducing the different elements of other diets, like go on full diets, and 2 weeks later or 3 weeks later, and work by exclusion, which food is actually causing you to have the irritable bowel. Now, you have to make sure that irritable bowel, irritable bowel and the symptoms is one presentation of endometriosis. And sometimes treating the endometriosis may treat the symptoms associated with it. I hope that helps.
Great answer.
That's fantastic. I'm just going to interject here, Firas, and just say what a great presentation that you just put to us. And it was really concise, but incredibly informative. So thank you. Yeah, I just wanted to come in and say that. So one of the questions that we had was, what proposals do you have for chronic pain sufferers for whom surgery due to bowel involvement is not an option?
Okay, so the management of chronic pain, it falls into different categories. And what do we talk about chronic pain? Chronic pain, is it abdominal pain? Is it pelvic pain? Is it crampy pain? Is it menstrual pain? Is it painful bowel movement that we have, or it could be a combination of these things. It also could be low back pain, and low back pain could be associated with endometriosis or separate from endometriosis. The approach has to be a holistic approach and has to be a patient, based on patient's needs approach. It is what is actually causing the pain, and how can we deal with it. Now, I have let's say, a way of dealing with this. Now, if surgery is not considered at all, then non-hormonal approach and medications would be always start, and the GPs like us to do this, paracetamol, like the ladder of pain, paracetamol. You add to paracetamol non-steroidals. Non-steroidals, you probably add opiates, like the form of codeines, and you go up that ladders, but it is you layer over layer, all right? And you don't stop this medication and go on a different medication. Then we have, apart from this, we have TENS machines that we can use, electrical stimulation. There are people who've spoken about alternative treatments like acupuncture. There are other people who have spoken about meditation, therapy. Then we go into neuroleptics, and that is amitriptyline, nortriptyline, and also go even further. But I think if we get to extent that we need specialist involvement, then we will always involve either the pain nurses or the pain specialist consultant, because we will have to think what else we can do. Then we also talk about the hormonal approach. So hormonal manipulation, like one of them is GnRH antagonist, switching off of the hormones in a fertile ladies, but that's giving them the menopause, may actually treat their pain, because the pain is as a result of ongoing endometriosis and a recurrent cycle of basically inflammation, fibrosis, and that's what's causing it. So hormonal manipulation has a big role, and that was a lot of the gynecologists use to control the pain and the activity of endometriosis. Now, I believe in lifestyle changes, because lifestyle changes, and that is diet. They talk about mindfulness, and also group exercise. I think you need, what I think is one example. I'm not just advocating that. One example would be yoga. Yoga is a form of physiotherapy. It's also a form of psychotherapy. It also it basically encourages general well-being, all right? And it's a group therapy. So you have it if you share your problem and you see people, it reduces your anxiety. It will improve in your mood. It will actually also takes away social isolation, because you feel that you are in a group and you are supported in that group. So that's as an example. Any group therapy would be of great help. I hope that answers this chronic pain.
That's amazing. Yeah, I'm absolutely in cahoots with all of everything that you've just said. That's a really wonderful way that you've taken the journey through the question. So yes, absolutely. And I advocate yoga, definitely, and endometriosis for myself. It does help a lot. It also can be done online. So if you feel that you can't make it to a place because you're in such pain, you can still just sit and do very gentle yoga online in a Zoom situation with your screen off if you don't want anybody to see you. So again, you know, there's ways of doing that. Yes, that answers my question, well, the question, sorry, really well. Do you want me to go to the next question? Catherine, just take it.
Yeah, John.
Yep. Okay, so question number 4 out of the 12 is, what happens for us to deep infiltrating endometriosis after menopause? If it's not surgically removed from the bowel, could it cause issues later on, or will it lay dormant?
Okay, so if we didn't have complex endometriosis and it didn't go to the extent that has caused fixity or narrowing or a stricture, then by the hormones in menopause, what happens is that the hormones are switched off. Okay, mainly the estrogen. It's the similar effect when we give GnRH antagonist. We switch off the hormones and we induce pharmacological menopause. What happens? The disease activity stops. It's less active, and a lot of patients actually feel a lot better on it. In the menopause, the same. The disease activity stops, but if you've had scars from all those years you've had endometriosis, to the extent that has given you a stricture or a fixed narrowing or a flexure, or obstructed your ureter, or obstructed the tube, or obstructed, then that problem will continue to give you pain. And I've operated on a significant number of postmenopausal women who had ongoing pain despite having had their endometriosis, despite going through the menopause. Also, if you go on HRT, you have to choose the type of HRT you go, and you have to go with an endometriosis specialist or a gynecologist's advice, because some HRT can continue to stimulate the endometriotic process. So in the vast majority, what happened is that endometriosis is less active.
Fantastic, thank you.
Okay, so the next one, how do you approach bowel endometriosis? Would you use ablation, excision, or fulguration?
Okay. The best way to deal with endometriosis is excision, but we are lucky that we have a fat pad around the outside of our rectum. So the rectum, while the tube is surrounded by a fat pad. A lot of endometriosis goes into the fat pad from the vagina or the cervix or the uterus into the fat pad of the rectum, and doesn't go into the actual bowel wall. So we can excise that fat pad and excise the nodular disease without excising the bowel. Now, it all depends on the depth of that endometriotic nodule into the bowel. Now, we are very conservative in our approach, and we would like to maintain, as I said initially in the presentation, maintain function, all right? Preserve organ. Now, if the organ is functioning well and it actually has a normal structure, then we can do the minimal. But if that organ is affected functionally, all right, by the endometriosis, then we will never get that function back unless we rectify the problem. And sometimes that includes sort of a disc resection where we take a segment of the bowel, or actually it may involve taking a bigger segment of the bowel. So it could be just a little disc like part of the wall, or it could take a portion of the bowel. It all depends on the extent of the disease. But we will do, every case is discussed as I explained, and every treatment is tailored to that patient's needs. And it's a joint decision making. So if the patient does not want any of these interventions, or would like to less intervention, then we can talk about it and the pros and cons. And the other thing is about endometriosis. The first time you go in, I think you should do the best job possible because it can reoccur. But what you want to do, you want to delay the reoccurrence as much as possible. All right? I hope that answers your question.
And I completely agree with that answer, given the surgery that you've given me over the years. That brings us nicely on to a resection question, actually. Do you prefer a resection or a shave on the bowel for endometriosis sufferers?
Okay. I don't take resections lightly. And I will only perform resection if I think this bowel, that's it. The endometriosis has mummified it, has fixed it, has narrowed it, or has damaged it to the extent that we cannot, there's no point operating without actually removing the endometriosis, because I would have served that patient no good. So if I would resect it, if I think this is damaged and this is beyond repair, I will shave it if I think it's only superficial and has gone into the fat. And the vast majority, that of the 1,000 probably cases I've done, I was successful in shaving it and preserving the actual organ. On the odd occasion, we will have to resect. But even resection, it's in 95% of the patients, okay, they recover with a very good outcome in the immediate, not immediate, I suppose, weeks after surgery, very good outcome. And most patients will have no stoma, and most patients will actually go back to normal bowel function as well.
Definitely. I can agree with all of that.
Fantastic. Well, you lived through it, Kat. So absolutely.
Good case study.
Absolutely. So the next question is it always necessary to have a resection to avoid persistence of endometriosis? But for us, you've actually answered that twice now. So I'm going to skip that question, Kat, if that's okay.
Yeah.
And just go to the next one, which is, sorry, so the answer to that is it's not always necessary to have a resection, and there are other options. So
yes,
yeah,
absolutely.
Yep. You're okay with it? I may pronounce this incorrectly, so please correct me if I do so. So another question is, have you ever studied about cytokine or cytokine secretion?
Yes.
Thank you. And how this can cause local inflammation?
I actually, to be honest with you, of recent, I haven't studied this, but cytokine is part of the inflammatory secretions that actually involved in the inflammatory process. And I suppose reduction of cytokine secretion does reduce the inflammation, and hence reduces the healing, and the healing is usually by fibrosis. I haven't done any research in that, but I'm sure there's research that people have done in that field. And hence we talk about, okay, how do we actually stop that cytokine secretion? Is by stopping the offending pathology. And if you minimize the actual activity of endometriosis, then you reduce the inflammation, and as a result of reducing the inflammation, then you reduce scarring. But I do not have sort of specific knowledge of that pathway or what happens in the immune reaction. But there is clearly an inflammatory process takes place in endometriosis.
I think my system froze there, so I didn't hear all of that, but I can do a replay, so that's fine. Thank you. I think, Kat, that's over to you.
Yep. Okay, so what is the recovery time from having a resection?
It depends on the extent. You see, a resection is only part of the operation that we do for endometriosis, and it's quite extensive in operation. It depends what else we are doing beside. On average, about a resection for a young patient, or vast majority of our patients are young, it takes them in hospital stay for about 4 or 5 days. If they're eating and drinking, they're catheter free, their pain can be controlled by simple analgesia, then they go home, usually on day 4. I always say 2 weeks at home of work, maybe of 3 weeks, and sometimes it can take up to 6 weeks. But the vast majority of patients, it takes them around a month, I would say, to recover from this. But consider how ill and how long you've been ill for. So to go back to feeling great and well in yourself, it depends how ill you've been feeling for a long time. And recovery is not only physical recovery, but it's physical, it's emotional, it's a bit of rehab, psychological, and that's all aspects. But I am happy to say that we have the team to support people to recover. And it's a well-established team now. I mean, Mildred would know more than I would and how long these patients can take to recover. But on our hospital stay, usually at the moment, with enhanced recovery, around 5 days or less for major resections.
Thank you.
That's incredible, isn't it? Incredible. Such a short amount of time. The care that you are giving at your centre, I've been through it as well. Kat's been through it. You know, we've both been through the care there, and it's incredible. The team is absolutely incredible. I cannot speak highly enough of all of you. Perhaps I've never met you before, but what you're saying is just very comforting and very honest and straightforward. Really appreciate that. Thank you. Sorry to interject.
No, well said. Okay, so this one's about MRIs. So is it possible to have an MRI scan of the bowels, the kidneys and the diaphragm area to diagnose endometriosis and deep infiltrating endometriosis?
Yes, it is. For the vast majority of cases that I come across that I am involved in would have had an MRI. Would have an MRI mainly of the pelvis to look at endometriosis. Our radiologist, she's excellent with an ultrasound. So you might start with an ultrasound and then go for an MRI. But part of the diagnostic process for endometriosis is usually history and physical examination, depending on what's actually required or depending on that. Then we basically go for investigations. Ultrasound is our first port of call. Ultrasound by a dedicated sonographer or radiologist in endometriosis is almost as good as any other modality. But if we think that this patient actually has severe deep infiltrating endometriosis that requires surgical intervention or planned treatment, then MRI. If we think there is any ureteric obstruction, then that may need a CT urogram to look at both kidneys and ureters, or may require an MRI. Now, the diaphragm disease is, if it's a nodular disease of around bigger than 0.5 centimeter, then we can see it. If it's only salt and pepper, okay, we cannot see salt and pepper, and that's only be seen with a laparoscopy, which is a direct visualization of the actual abdominal cavity. So sometimes we do miss spots in them because endometriosis can be anywhere and can be, we can miss it. But we can have a combination of ultrasound, MRI, and CT, and that depends on the radiologist, what they think is the best modality, but it's all available, and we use every modality possible to actually establish a diagnosis.
Fantastic. So we have 2 questions left for us, so very exciting. One of them is, are consultants like yourself trained to diagnose endometriosis via an MRI scan, which you've just basically answered, so I'm going to skip over that one and just go to our last question. So yes, you're absolutely using every modality. So last question that we have is, if a bowel resection is performed and the endometriosis is also removed, could it come back into the bowel later on?
Okay, so in my mind, endometriosis can be we can have nodular disease. And the nodular disease, that can be solitary, like only one nodule, or we could have multifocal disease. Now, the less number of nodular diseases we have, the better outcome we get. Okay. Also, it may have structuring disease. So if it has structures, then we remove the structures, then it's less likely to come back. And those structures could be either the tubes, or could be the bowel, or could be the ureters. So the most important thing is having basically a dedicated surgical team that deals with this and do it well for the first time. Now, unlucky that I always am either the third person or the fourth person or the fifth person that goes into the abdomen after the patient has had multiple laparoscopies in the past. And I see a lot of recurrence. Now, my aim and our center is to minimize the risk of that recurrence, but the risk of recurrence in conservative managed endometriosis after laparoscopy is about 20%. But radical surgery, which is a pelvic clearance surgery, is just a lot less likely to reoccur. Now, I'm adding something else. Now, we recently have actually purchased a robot, and the robot, which has come to our hospital only about last week, and I'm lucky to be the first one to be using it in the near future. It has cost over 2 million, and the robotic surgery, it will push back that boundary and the future of surgery in the pelvis. It's going to be unlimited. We're going to have 3D binocular vision. We're going to have indoor wrist technology. We will be able to do things that we were not able to do ever before laparoscopically, and will also will increase our accuracy, nerve preservation, organ preservation, and also increases our ability to take very difficult endometriotic nodules and give the ladies the best service they deserve.
That is amazing.
Wow. I think every woman that watches this is just going to go, wow. Wow. I can't say anything else. Yeah, incredible. That is fantastic news. You've just given us such a gift this evening whilst we're recording this for us. Thank you. I'm a little bit lost for words, and that's unlike me. Thank you. Thank you.
My absolute pleasure.
When do you think you might get a chance to sort of use the robot as it was?
So my first case is going to be started on the 2nd of May. So I basically myself and another gynecologist is the Muntasar Mahran. He is also training. He's from Bedford, and he comes across to do endometriosis with me, because there's nobody else that does it in Bedford. So he comes and does endometriosis with me on complex cases, things that require me, of course. And he's at the same time, he's training on the robot at the same time. And every morning I go in about 7 o'clock in the morning, I spend an hour. And in the evening, I spend an hour on it in the simulation. My first live case would be in the 2nd of May. And I will be doing 2nd, 3rd, 9th, 10th. So I would start, and that is basically called a training on robotic surgery. So I'll be starting there, so not too far. And I'm hoping that in the future, all my endometriosis cases will be done robotically.
That'd be wonderful. Really wonderful.
Yes, indeed.
And what a lovely way to finish the webinar set of questions as well. A nice bit of good news.
Yeah, absolutely.
That is fantastic.
It's
been a real pleasure to have you both with us today. Yeah.
My absolute pleasure.
Thank you for having me.
Oh, thank you very much.
Always. And Mildred comes to our support groups. So we are the Endometriosis UK support group for Bedfordshire. And Mildred and Jane does come, they both come every 3 months that we do it and meet people just in the Starbucks coffee shop, and we talk about endometriosis. And your name is said a lot. We see other names come up left, right, and centre. And it's a real honour to have you be here and then cascade it out to women that are just asking. These are genuine questions that come from genuine women that are battling through endometriosis on a daily basis. So yeah, it's huge what you've done today.
Yeah. Thank you
to Mildred.
Thank you, Kat and Deb. It's been really lovely, supporting the group because we really want an aim to be a better support to the ladies who are suffering with this condition. We can only do so much for you, and we're hoping we're doing something for you.
Oh, you are, most definitely.
Loads. Lots. Yeah, you're really making a difference, and we're really seeing the change that comes through. When I started with the group, I think it's about 8 or 9 years ago now, and it was a very, very different scenario. So it's come on leaps and bounds, and I realise that we've still got such a long way to go. But the news that's coming through, and for us just saying about the robot, it is huge. It's groundbreaking at the moment, and grateful are the women that are in your care for sure.
And obviously having the leading expert in terms of reading the MRI scans and the ultrasounds and things like that, that's a huge step forward in, diagnosing the ladies as well. So that's really important too.
Yeah. Thank you.
Thank you for hosting me today.
Thank you very much, Mr. Yunus. Thank you, Deb.
Thank you for joining.
Our pleasure. Thank you.
I bid you goodbye.